always find it very interesting when we talk to founders who the scientific or the science of the biotech company wasn't your discovery initially. And you're kind of you're this entrepreneur who kind of finds technologies, and you're good at advancing them and kind of connecting dots, like you say. What exactly, and I think that it lends a little bit of authenticity and credibility to the technologies that you choose, because you don't have any kind of preconceived biases. Like, this was my discovery, so I want, I believe in it because I made the discovery in my lab 15 years ago. So the question that I have for you is, what drew you to natural killer cells? You obviously have some kind of inclination towards NK cells with Cytovia and with NAYA now. What exactly was the appeal to NK cells over something like T cells or other kinds of modalities?
So I mentioned in the introduction that my background prior to being an entrepreneur is with big pharma, also in strategy consulting, mostly with big biotech and big pharma. And there, I was on the development side, but also on the commercial side. So I pay a lot of attention, and I think my team as well, pays a lot of attention at proof of relevance. What is the target product profile, and is it going to be relevant to physicians and eventually useful to patients? So, coming back to your question about NK cells, I think the NK cells were overlooked for a long time. They're extremely cytotoxic. They're safe, compared to T cells, and also they're much easier. When we started with cells, not with the engager, they're much easier as an allogenic, product.
Yeah.
And that's a big advantage when you want to, cure cancer in millions of patients, not just in the happy few that are treated at Memorial Sloan Kettering or Dana-Farber.
Sure. Yeah, and I think that, this might not apply to hepatocellular carcinoma, depending on the treatment landscape. But I think that one of the big advantages of NK cell-based therapeutics is the ability to use them in patients that might not be able to handle the potential risk of, like, cytokine release syndrome or the potential toxicities of T cells. So is there any kind of plans moving forward to treat patients that would normally not qualify for a T cell therapy, for example, with NK cells?
Sure. So let me step back a second. So initially at Cytovia, we had the conviction that our NK cell engager would work best in combination with the NK cells.
Yeah.
And until we were able to demonstrate in preclinical studies that actually we reversed the dysfunction of exhausted NK cells, and that we could use them as monotherapy. And in fact, our first clinical trial is monotherapy in non-responders to first line immunotherapy. So that's the first point.
Can I jump in for 1 second there? Because there's two dimensions to the differences between NK cell and T cell therapies. One of the big differences between, like, a T cell engager approach and an NK cell engager approach is the fact that the majority of the lymphocytes in a person are T cells. A vast minority are NK cells. So there's two dimensions to the combination of allogeneic NK cells with an NK cell engager. The first dimension would be to provide cells that aren't exhausted. So if you show you can overcome the exhaustion, then you kind of get rid of that dimension, right? But the other dimension would be you can provide a large quantity of NK cells. Now, you mentioned Innate Pharma earlier. Innate Pharma's big unlock to me is the inclusion of the IL-2 component, which is known to expand NK cells. So they can kind of overcome the quantity problem. Can you speak to the potential downside of an NK cell engager without the addition of an NK cell therapy, with the problem of not having enough NK cells around to perform the function?
So I think it's a very relevant approach, and it's an approach that we're also considering. Obviously, there's an arbitrage between IL-2 and IL-15, but I think it's relevant as next generation product. In the meantime, what we have demonstrated is that through NKp46, we are helping the migration of NK cells from the periphery to the tumor site, and in the tumor microenvironment that we're reactivating exhausted NK cells, and that should be more than enough for a clinical effect. So, not to say that the next generation with a fused cytokine doesn't make sense. We think it does, but practically, also the limitation of the NK cell engagers for a long time is that they were focused on CD16, and CD16 by itself doesn't kill sufficiently, and also is shedded, particularly in solid tumors, which is not the case of NKp46.
Right.